responses. Looking forward to this talk.
Good.
Robby, when I introduce you, just mute so that we don't hear that back echo. And then as soon as I'm done introducing you, I'm going to mute myself.
Okay. Let me mute myself for now then.
Perfect. Yeah, that way it doesn't backlash too much. So. All right, we'll wait one more minute and then we'll get rolling. All right, we're just under 30 participants, so I think we're ready. So good afternoon, everybody. Welcome to the Thursday Roy Benke Department of Internal Medicine Grand Rounds. Joel Azama, Vice Chair of Education here, your usual host for these Thursdays. Thank you for a lot of the feedback we've gotten from Grand Rounds so far this year, and I think it has been a great variety of topics that we presented. And this was going to be our first cardiology topic of this academic year's Grand Rounds. And we have an excellent speaker with us from our Department of Internal Medicine, Division of Cardiology, and that is Dr. Robby Wu. Robby has been with us for 3 years now on faculty. This is year 4 for him. Time flies. So Robby graduated from the Philadelphia College of Osteopathic Medicine, then went to Danbury Hospital. That's with Yale University School of Medicine, and that's where he did his internal medicine. Then came into the Tampa Bay area for doing his cardiology fellowship with Northside Hospital and the Tampa Bay Heart Institute, and then joined our advanced heart failure and transplant cardiac fellowship, and he did that graduating in 2020. Robby is a very, very distinguished speaker, and he's already done fantastic work as a young member of the faculty, double digits in his journal submissions and poster presentations. And really, his talks on hypertrophic cardiomyopathy have been recognized by so many members of the Division of Cardiology that when I was looking for a speaker for a cardiology topic, Robby's name kept coming up for speaking on HOCM. So with that, we'll introduce without further ado, Robby Wu, speaking about hypertrophic cardiomyopathy in 2023. Take it away, Robby.
Well, thank you so much for that kind of. There we go. Can everybody hear me now?
Loud and clear. You're good.
Okay, great. Well, thank you for that kind introduction, everybody. It's an honor to be speaking at Grand Rounds. I'm really delighted to be here. I'm sorry my camera is not working. We'll look into that for next time. But really, this is a topic that I'm really delighted to be speaking about. And it's been a topic that I've been very passionate about for the past 2 or 3 years now. And really, for the hypertrophic cardiomyopathy enthusiast, it's a great time to be interested in this field. There are a lot of new targeted therapies available. There are new diagnostic and treatment modalities coming out. So it's a really exciting time to be interested in hypertrophic cardiomyopathy. And I hope that this presentation today will help you see that. And so there are a lot of new advances. And so today we're going to be talking about these new contemporary approaches to HCM. I do speak for a couple of pharmaceutical companies. I will not be selling any of those medications today. But here is going to be the flow of today's talk. So we're going to start off with a case presentation. We'll talk about an introduction to HCM. We'll talk a lot about diagnosis and recognition. We'll talk in depth about sudden cardiac death risk, genetic testing. We're going to spend some time on exercise recommendations, and then we'll talk about treatment strategies for HCM that we have in 2023. And then we'll wrap up with a summary, and I'd be happy to answer any questions afterwards. With this case presentation. So this is Mr. G. I have an echo here. I'm just gonna give me 1 second. There we go. So this is Mr. G. So Mr. G is a 30-year-old gentleman that presents with progressive dyspnea on exertion and shortness of breath over the past couple of months. And I won't belabor his social medical history. I think we're all pretty familiar with Mr. G. He's not so fond of the holidays, has engaged in some high-risk behavior with some burglary and breaking and entering. And on Christmas Day, he hears the town singing and is overwhelmed with emotion. And on that day, his heart grows 3 times the size that it's supposed to be. And we're all in medicine here. So we know that's not normal. That's pathologic. So he's subsequently diagnosed with cardiomyopathy, and I see him in clinic in our hypertrophic cardiomyopathy clinic. And at that clinic, we find out that Mr. G has also been diagnosed. His brother has also been diagnosed with hypertrophic cardiomyopathy and has a defibrillator. So caveat, Mr. G is actually based on a real patient that I see in clinic. The actual patient loves Christmas, but also has a very enlarged heart. And also my disclaimer that I don't own any of these images. But let's go back. Let's go back to this diagnosis of hypertrophic cardiomyopathy. So if we look at the most recent iteration of the guidelines, which were released in 2020, we could see that a clinical diagnosis of HCM in adults can be established with 2D imaging showing a wall thickness of 50 millimeters anywhere in the left ventricle. And so the most important part of this, however, is that this is in the absence of another cause of hypertrophic cardiomyopathy, of hypertrophy in adults. So really, this is a diagnosis of exclusion. And so our job then is to really distinguish pathologic hypertrophic cardiomyopathy from any of the other phenocopies that can mimic it, anything else that can thicken the left ventricle or any other area of the heart. So these phenocopies include hypertensive heart disease, athlete's heart, amyloidosis, glycogen storage diseases, and other infiltrative genetically mediated diseases that we see, such as Fabry's disease and Danon disease. And the thickness can occur anywhere in the heart. And so 10% of the time we have this neutral HCM where it's a concentric left ventricular hypertrophy. And I would say the majority of the time we see it in the septal area. So asymmetric septal hypertrophy, which we recognize in this reverse curvature area. We know that depending on the phenotype of this expression, there are different genotypes associated with them as well too. And so in 10% of apical hypertrophic cardiomyopathy, we only see a 30% gene positivity. Whereas if you have the asymmetric septal hypertrophy variant, 80% of the time we'll identify a genetic variant. And it's described all over the world. So over 120 countries across the world have described some form of hypertrophic cardiomyopathy. We see it on all 7 continents. We estimate the incident to be about 1 in 500 individuals. It's probably more than 1 in 200 patients. And so we know it's very underrecognized, it's very underdiagnosed, and we see it across all ethnicities, races, genders, across the whole spectrum of the world, really. And it's actually more common than other diseases that we encounter in internal medicine, HIV, cystic fibrosis, rheumatoid arthritis. HCM is much more common than all of those things. And so if you think you're not seeing it, you probably are. And so my job today is to hope you maybe be a little more aware of what we're seeing and to help recognize and diagnose this entity. And it's described by obstruction. And so you can see in this graph here that what really defines HCM is this increased interventricular septum or anywhere in the heart. And we also see this elongated anterior leaflet of the mitral valve. And when that long anterior leaflet bumps against this hypertrophied interventricular septum, you can see that blood flow then is unable to get out of the aorta. And so this is what causes patients symptoms of obstruction. And by definition, we ascribed this obstruction by gradients that we identified via echocardiogram. So arbitrarily, we'd identify obstruction as more than 30 millimeters. And then obstruction warranting septal reduction therapies we define as greater than 50 millimeters. But really, these signs of obstruction can vary from individual to individual. So we see chest pain, particularly with physical exertion, shortness of breath, fatigue, arrhythmias, lightheadedness, and syncope. And so these are fairly non-specific findings, but in the context of hypertrophic cardiomyopathy, can really let you know that that patient is not getting enough blood and enough forward flow. And the classic teaching is about a third of patients will obstruct, a third of patients will have provocable obstruction, and then a third of patients will not obstruct. And these are dynamic processes. And so we call it dynamic obstruction for a reason. And that's that they can vary from minute to minute, second to second, and hour by hour. And these are all dependent on the patient's loading conditions. And so across all patients with hypertrophic cardiomyopathy, about 46% of patients will have no issues at all. And so that's very reassuring and something that I like to tell patients as well too. Another 43% of patients will have progressive heart failure. Like I said, a third of those will have obstructive hypertrophic cardiomyopathy, and we manage that medically, which we'll talk about in a little bit. Less than 4% of patients will go on to require advanced heart failure therapies for non-obstructive symptomatic heart failure secondary to their hypertrophic cardiomyopathy. And those are the less than 4% of patients that we go on to refer to transplant. And we've transplanted a few of those in our program here. About 17% of patients will develop atrial fibrillation, and about 6% of patients will have sudden death events. And we'll talk about each of these in turn as well too. And so this is how patients present to either your clinic or my clinic. Either patients have an abnormal physical exam, they have an abnormal electrocardiogram, they have an abnormal echocardiogram, or they know that they have it. So they have a family history. My dad has hypertrophic cardiomyopathy. My brother was just diagnosed with hypertrophic cardiomyopathy. And these are the way that patients present to you and I. And so the classic physical exam findings is what we all learned in medical school. So the rapid carotid upstroke, sometimes called BIFID because you can feel it twice. The apical precordial pulse, which is laterally displaced and diffuse. Sometimes we call that the triple ripple because you can feel an S3 as well too. And then what really classifies it is this medium pitched crescendo, decrescendo systolic murmur along the left sternal border. And so this sounds almost exactly like our aortic stenosis murmur that most of us are very accustomed to hearing. Except, as we know, this if it's attributed to hypertrophic cardiomyopathy, it increases with decreased preload. So either with a Valsalva maneuver or squat to stand, those things will accentuate the murmur. And sometimes if I'm looking for a murmur and I can't hear it, I have the patient squat 10 times in the clinic, and I do it with them. And that generates some forward flow to decreases their preload, and then you can hear the murmur much more audibly. A lot of the times too, you'll hear a concomitant holosystolic mitral valve murmur, mitral valve regurgitation murmur, and this is really associated with obstruction and systolic anterior motion of that mitral valve. So this is Mr. G's electrocardiogram, and hopefully you can appreciate the diffuse LVH criteria that you see associated with those T-wave inversions. And remember, Mr. G is 30 years old. And so any 30-year-old or young person with this kind of electrocardiogram really demands further investigation. This was a study done by Lakdawala et al. In 2014, and what they looked at was healthy controls, where you see in the white bar graph, and they measured that against genotype positive phenotype patients with hypertrophic cardiomyopathy, which is the black graph. And then the gray is sort of in between where they have genotypic expression, but no phenotypic expression of hypertrophic cardiomyopathy. But really, if you look at the healthy controls versus what they call overt hypertrophic cardiomyopathy, you can see that the most specific electrocardiogram findings of HCM are Q waves, early repolarization, and T wave abnormalities. And so those things should make you strongly suspicious for a diagnosis of hypertrophic cardiomyopathy. But remember, in this study, about 10% of patients with hypertrophic cardiomyopathy did not have changes. They had a normal electrocardiogram. So by itself, a normal electrocardiogram is not enough to exclude a diagnosis of HCM, but it's really helpful for screening purposes and for making this diagnosis, but never alone. This is a patient that was referred to our HCM clinic a couple of months ago, and you can see, sure, she has a true a thickness of the heart, so a thickened myocardium. And this was his electrocardiogram. And by the electrocardiogram, hopefully you can appreciate that there is actually low voltage criteria, and the voltage criteria is way out of proportion to the thickness that you see on the echocardiogram. And so when I saw this, we did some additional digging. We ordered some lab tests, and we ended up ordering a pyrophosphate scan. So if you're not used to looking at pyrophosphate scans, we're comparing the uptake of the heart, where you see here, to the uptake of the contralateral rib here. And in normal myocardium, there should be no uptake of the heart here. So this should be black, just like the other side of the rib here. And you can see from this pyrophosphate scan here, this is extremely positive. There's a lot of uptake in the entire myocardium. So this is a PYP, a positive PYP scan, and thus this is diagnostic of transthyretin cardiac amyloidosis. And so this is just an example where the electrocardiogram can sort of help you discriminate between those phenocopies of HCM that we talked about. But of course, as I said, you can't rely just on the electrocardiogram. The mainstay of diagnosis of this disease is still echocardiography. So 2D echocardiography remains the best modality that we have for confirming a diagnosis of HCM. It's quick, it's easy, it's readily accessible, and it gives us a lot of information about the anatomy and the areas of obstruction in the heart. So this is Mr. G's actual echocardiogram, and you can see here in this 4-chamber view significant myocardial thickening, particularly in the septum here, but really everywhere throughout. And then we see here significant obstruction with Valsalva as well too, with a peak gradient of 98 millimeters at the LVOT with obstruction. And so echo gives us a lot of information. And so we use it to help measure myocardial thickness. So we can see here the thickness of Mr. G's heart is 2.6 centimeters. We can tell from the cine images that there's a lot of mosaic attenuation here, which is suggestive of increased flow acceleration, which tells us that he's obstructing. We can also see that this is the anterior leaflet of that mitral valve here. It's touching that septal leaflet, that septal area. And so this is descriptive of that systolic anterior motion that we were talking about. And so it does provide us a lot of good information, but I will say you are sort of at the mercy of your sonographers there. Depending on where you place the probe, you can underestimate, overestimate sizes as well too. So there are cons to using echocardiogram as well. Tissue Doppler imaging is a normal part of our assessment, is a normal part of the echo assessment, and is really helpful in distinguishing HCM versus other of the other phenocopies. So in patients with hypertensive heart disease or athletic remodeling, those patients should have normal diastolic dysfunction. Whereas on the contrary, patients with hypertrophic cardiomyopathy almost always have some sort of diastolic dysfunction. And so this tissue Doppler imaging is really how we quantify, identify, and grade diastolic dysfunction. And so it's another tool and another part of the echo assessment that can help us discriminate between athlete's heart, hypertensive heart disease, or hypertrophic cardiomyopathy. The use of strain is very institutionally dependent. We use it more here at Tampa General Hospital. And what strain does is it assesses for deformity and it measures the contraction of the heart. So you can see here, we're in this bullseye point, we're sort of delineating it by segment. So this outer rim here correlates to the basal area. This middle circle here correlates to the mid-myocardium, and then the center target here correlates to the apical myocardium. And red, the more red it is, means that the more that myocardium is contracting. So here in the red here, you can see that the heart is uniformly contracting in all areas. And this is what we would expect to see in a normal heart, in an athlete's heart, and in a hypertensive heart. When you compare that to hypertrophic cardiomyopathy, we see that there are regional variations. And so the heart contracts less here where it's more thick. And so this is a useful tool, again, in discriminating. Cardiac amyloidosis also has a very classic cherry on top apical sparing pattern that we see here. And so, I never rely completely on the strain pattern, but again, much like the electrocardiogram, it's another tool that we can use to help discriminate between the other phenocopies that we see of causative agents of a thick myocardium. And cardiac MRI has become really a very critical part of the diagnostic algorithm for hypertrophic cardiomyopathy. So this is Mr. G's cardiac MRI, and you can see the beautiful delineation where it just provides excellent spatial resolution and tissue characterization of the myocardium. So great things about cardiac MRI: superior spatial resolution, accurate volumetric assessment of all four chambers, and then superior tissue characterization. So there are specific sequences that we can use in the cardiac MRI too, T2 star imaging, T1 mapping, and these also help identify against other infiltrative diseases such as amyloidosis, hemochromatosis, and it can also help us discriminate against athlete's heart and hypertensive heart disease. But I think the biggest value that cardiac MRI has provided us is that it has really helped us identify scar burden, and it has really helped us identify myocardial fibrosis. So this was a study, this was a large meta-analysis performed by Wang et al. That really helped us delineate the prognostic value of late gadolinium enhancement in hypertrophic cardiomyopathy. And in this study, the authors concluded that the presence and extent of late gadolinium enhancement was not only an independent risk factor for sudden cardiac death, but for also other adverse events. So it helped to prognosticate heart failure hospitalizations, all-cause mortality, and things like that. And so it's become very, very useful. And in fact, it's got excellent negative predictive value as well too. So in patients that don't have any late gadolinium enhancement, their outcomes are excellent. And so this has really become a really useful tool in helping to risk stratify patients that have hypertrophic cardiomyopathy. And that's why the cardiac MRI has become very important for the diagnostic findings in this disease. This is an image that that I stole from our imaging fellow, Dr. Chris Skoma, and he put this together and really just highlights the beautiful high resolution images that we're able to obtain in cardiac MRI. And so there are different treatment modalities that we can offer to different people depending on their variant, depending on where their myocardium is the thickest. And so having really good anatomical definition of where the myocardium is thickened is very, very useful. And so this is where cardiac MR has been exceedingly helpful. And as I said, it's difficult to distinguish between hypertrophic cardiomyopathy and athlete's heart. And so here are some characteristics that can help you delineate that. And the gray zone, I would say, is that area between 13 millimeters and 15 millimeters. Remember, 15 millimeters is diagnostic for hypertrophic cardiomyopathy. And I would say it's almost impossible for an athlete to train above 15 millimeters. And so if you have an athlete that has a wall thickness of greater than 15 millimeters, I think HCM certainly has to be on your differential because, as I said, athletes can it's almost impossible to train your heart to above that. But the gray zone is this 13 to 15 millimeter area. And so some things that lean more towards HCM are late gadolinium enhancement on your cardiac MRI, a strong family history of HCM, abnormal diastolic filling pressures, bizarre ECGs, and large and small cavity sizes. So those all point you more towards hypertrophic cardiomyopathy. The heart is just like any other muscle. And so if you detrain the heart, it also decreases in thickness. It's usually hard to convince an athlete to detrain, however, and most are pretty unwilling to do that. But it's another method that you can use to help discriminate. So let's go back to our case presentation. This is Mr. G's cardiac MR that he had a while back, and you can see he has normal LV systolic function, 61%. And he does indeed have asymmetric septal hypertrophy with a maximal wall thickness of 30 millimeters in the mid-inferoseptum. Concerningly, there are also areas of mid-myocardial fibrosis that are elucidated by late gadolinium enhancement. And over here are his actual images. So these are the delayed enhancements, and late gadolinium presents as white on these delayed enhancement sequences. So you can see here, all this white here is dye extravasation. So it's late gadolinium enhancement. And as we said, this portends a very unfavorable prognostic finding. And so now we have to have a very in-depth discussion about sudden cardiac death risk. And so overall, the risk of sudden cardiac death with patients with hypertrophic cardiomyopathy is about 1% per year. And there are a couple of things that elevate that risk, which we'll talk about. But also worth mentioning that sudden cardiac death, as we know, is the most HCM is the most common cause of sudden cardiac death in our young athletes. And so in patients less than 30 years old, it's the most common cause of sudden cardiac death in about 36% of the time. And so, of course, if you've had a prior event, if you've had sudden cardiac death before and you're successfully resuscitated, I think that's a no-brainer. That's a class 1 recommendation to proceed with defibrillator implantation for now secondary prevention of sudden cardiac death. There are a couple of other things that I think elevate that risk beyond the normal 1% per year. And so if you have a family history of a first-degree relative for sudden cardiac death, we know that that's an adverse prognostic finding. And that warrants further discussion. Massive LVH we define as 30 millimeters or more. And this is a continuum. So it's not as if you have a 28 millimeter of myocardium, we say it's okay, and you have 31, we recommend the defibrillator. We know that this progresses in a linear fashion, so that the thicker your walls are, the more at risk you are for having an arrhythmic event. And so the cutoff is 30, but as we'll talk about, it's all about shared decision making. And so unexplained syncope, an apical aneurysm, and an LVEF of less than 50%, all these are really high risk findings on echocardiogram that portend a poor prognostic event. I frequently get Holter monitors to evaluate for non-sustained VT. And then, as we already talked about, extensive late gadolinium enhancement on your cardiac MR, all these things are unfavorable. Extensive is defined as more than 15%. Our radiologists here don't quantify it, and so, but that's something that we're working on. But that's something where you can discuss it with the patient. And so really though, I also wanted to mention that there's an AHA sudden cardiac death calculator. You can just Google AHA SCD, and this calculator pops up. And you can type in the patient's age, their thickness, and they'll ask through all these risk factors. And when you've input all those numbers, it spits out a 5-year risk of having sudden cardiac death. And some patients need this, right? Some patients really want to know, what is my risk? And if you can give them an objective number, Mr. G, you're going to have a 4.6% of dying in the next 5 years, it gives them a tangible number for them to grasp. But we're trying to shy away. We're trying to change how we approach these decisions. And I always tell patients having a defibrillator for primary prevention is a lifelong commitment, right? And so we have to weigh the risks and cons, the risks and benefits of that. And so the guidelines really advocate for shared decision making, and you really want to discuss the risk tolerance of your patient. If they are absolutely certain that they don't want a defibrillator, that's okay. But as long as they understand the risks, and this shared decision making will come into play when we talk about exercise as well too. And so Mr. G's risk factors. So he does, as we saw, have 30 millimeters thickness at the mid-infroseptum. He does have some late gadolinium enhancement, pretty extensive late gadolinium enhancement on his cardiac MR. And I did do a Holter monitor, which indicated some non-sustained ventricular tachycardia on Holter monitoring. So we discussed this a lot. There is a baby G and a Mrs. G. And so he decides to proceed with ICD implantation. And just a word about HCM and atrial fibrillation as well too, as long as we're talking about arrhythmias. So AFib, as we know, is the most common arrhythmia that we see worldwide, and it's the most common arrhythmia we see in hypertrophic cardiomyopathy as well too. And as we discussed previously, almost 20% of all patients will develop some form of atrial fibrillation along their lifetime. In contrast, distinction to normal healthy adults, though, atrial fibrillation, because of the loss of atrial contribution and because of worsening diastolic dysfunction, AFib is really, really poorly tolerated in patients with HCM. And so it's really important to get them under control. And so it's actually a class 2A recommendation to pursue a rhythm control strategy up front. Most patients are already on some sort of AV nodal blocking agent already anyway, with either a calcium channel blocker or a beta blocker. And so a rhythm control strategy is really preferred in these patients. And you treat these just as you would with any other patients as well too. So you can use amiodarone, desotalol, dofetilide, any antiarrhythmic medication. We also do catheter ablation with patients with atrial fibrillation. We try not to do that up front. There is so much fibrosis and scarring and myocardial disarray in these patients that ablations, one, never really take, and they frequently require additional ablations once you've done the original one. So I really try to do a good trial of antiarrhythmic therapy first, and then utilize catheter ablation as a next or second to last option. Very, very important to know as well too that your risk of stroke increases tremendously with hypertrophic cardiomyopathy and atrial fibrillation. So having HCM in and of itself is akin to having a CHA2DS2 VASc of at least 3. And so the guidelines are very clear. Regardless of their CHA2DS2 VASc, a patient with atrial fibrillation and hypertrophic cardiomyopathy should be anticoagulated. And so you can use a DOAC, you can use Coumadin, but as a first line, at the very least, stroke prevention should be at the top of the forefront. And these patients should be anticoagulated regardless of CHA2DS2 VASc score. So Mr. G goes on to ask, as we know, my brother tested positive for an HCM gene. Should I get tested too? And as we discussed, HCM is the most common inherited cardiac condition that we see. We identify a causative genetic variant in about 30 to 50% of patients that we see. And so most patients actually do not have a sarcomere mutation attributed to their disease process. When we find it, though, it is an autosomal dominant disease that we see in a Mendelian fashion. And so if a patient does have it, there's a 50% chance that one of their family members will have it too. So we have 11 plus genes that we've identified with multiple different variants. Myosin binding protein C and myosin heavy chain 7 are by far the most common. And these are all genes that are attributed to the troponin gene at the sarcomeric level of the myocardium. And very importantly, while it's important to screen family members for genetic testing reasons and for cascade screening reasons, I always tell patients that a positive genetic test doesn't influence what I do for them. So a genetic etiology does not reliably predict prognosis. It doesn't prognosticate future clinical events, and it doesn't help to look into the future and assess clinical outcomes. And this is including the risk of sudden cardiac death. So it's not required for the diagnosis of hypertrophic cardiomyopathy, and it doesn't change how I treat them. But it is important for screening of family members. The other area where genetic screening can be important as well too is that it can help elucidate a difficult diagnosis. So occasionally we'll have patients that are sort of borderline, we call them possible HCM, where I'm not fully convinced that they have hypertrophic cardiomyopathy, but they are extremely suggestive. And so occasionally the genetic screening can help identify that and can help determine other genetic variants of a hypertrophied heart. For example, transthyretin cardiac amyloidosis has a genetic variant that's ascribed to it. Fabry's disease has a genetic variant that's ascribed to it. So occasionally, genetic testing can help you go down those pathways. And as we know, the treatment strategies for those disease processes are markedly different than one for HCM. So for diagnostic purposes, it's helpful as well too. And so we have a long discussion with Mr. G as well too, to see if genetic screening is going to influence anything that he does, if it's going to be helpful for him. And as I mentioned, there is a Mrs. G and a baby G, and so he would like to get tested. And he also tests positive for the same gene that his brother has, MYJ7. And so here is sort of an algorithm of how we should approach genetic screening in 2023. And the rule of thumb is always to test the patient with the disease. So we never test anyone without the disease. So anybody that suspect has the disease or has the disease, you test that patient. And then once you identify that gene, you can do cascade screening in the family members for that positive gene. And if that gene is positive in the family members, then this warrants follow-up. This warrants screening. For example, if Mr. G's child tested positive for MYJ7, even if they were phenotypically negative, as children normally are, it would require routine annual screening just to make sure that they don't develop phenotypic expression of the disease. On the other hand, if the family members are negative, then you can stop screening, and you can be confident that that patient will not develop this disease process. Occasionally, we also identify variants of unknown significance. And those are sort of like the maybe we're not sure what to do with this information yet. And it is important to rescreen patients every 5 years. As I mentioned, we have over 11 genes that we've identified as causative agents of HCM. We're identifying new variants and new sequences almost every year. So I do find it important to rescreen patients every 5 years if they either have a benign variant or VUS, because a benign one now or a VUS now could become pathogenic in a couple of years. And then another question that Mr. G poses is, I used to go to the gym and lift a lot. Can I still do that? Can I still do that in 2023? And I would say to Mr. G, it depends on when you ask this question, right? If you had asked this question in 2011, when Mr. G was just a baby G at that time, I would say no. And if you look at the 2011 guidelines at that time for treatment of hypertrophic cardiomyopathy, it was a class 3 harm. Patients with HCM should not participate in intense competitive sports. And it was even a 2A recommendation at that time to do anything at all, to do even in low intensity competitive sports like golf and bowling. That was a 2A recommendation. We now know a lot more, and we now have a lot more data. And I think we have a lot of data to show that those recommendations were probably a little bit harmful to the patients at the time. So we know that only 45% of patients with HCM meet the minimum guidelines for physical activity. And most patients, many of them, report intentional reduction in exercise following diagnosis. And so this is harmful for a majority of the patients. And we all know about the cardiovascular benefits of exercise. And those certainly hold true with patients with HCM as well, too. In 2017, there was a reset trial, and this was to assess the efficacy of a trial of moderate to intensity exercise in patients with HCM. So this was a smaller trial, 100 some patients, and they ascribed them to medium or high intensity exercise, and these are all categorized by metabolic equivalence. So moderate intensity, high intensity is about 4 to 5 METs. And remarkably, we found that in these patients, they do have increased VO2, meaning increased exercise tolerance. But the most important part is that there were 0 safety events that they found in these 100 or so patients. Fast forward to this live HCM study that was just published within the past year, and this was a much stronger data that we have to support this. And so the Live HCM studied about 1,600 patients, and this was a prospective observational trial studying over 1,600 patients with hypertrophic cardiomyopathy. And a number of them were ascribed to vigorous exercise. So vigorous in this study meant 6 metabolic equivalents or more. So swimming, running up a hill, bicycling 13 miles an hour. A number of these patients were participating in vigorous exercise. And you can see on the Kaplan-Meier curve on the right that there was no signal for harm. There was no statistical difference in patients that did vigorous exercise or non-vigorous exercise. And if you look at the patients that did have sudden cardiac death in both the patients in sedentary lifestyles and vigorous exercise, you can see that most of the events happened doing normal things. So sleeping, being home alone, driving a car. Most of these events did not happen while doing exercise. And so this was really powerful information. And I think this really challenged the dogma that we've had for the past 4 decades now that patients with hypertrophic cardiomyopathy should not do anything at all. And so the pendulum is really swinging now. And so now it's a class 1 recommendation. These are the 2020 guidelines. It's a class 1 recommendation for all patients with HCM. They can participate in mild to moderate intensity exercise just to keep them healthy, just to improve their quality of life, and to keep up with their physical activity needs. It's a 2A recommendation to provide proceed in low intensity competitive athletics. And in patients that want to participate in high intensity recreational activities or competitive athletics, it's now a 2B recommendation. And really, this should be a part of shared decision making with a person, with the individual, the patient that has the disease, and the physician that's taking care of them. And the AHA really recommends that these patients be followed at a comprehensive hypertrophic cardiomyopathy center with experience in taking care of these patients. And really, it should be a discussion amongst all party types with the patient's primary care physician, general cardiologist, specialist cardiologist, and the patient's family. And really, in these discussions, you really want to know, again, sort of as we discussed with the ICD implantation, what's the patient's risk tolerance and who they are as people? Is this patient's identity being an NFL football player such that they are willing to take the risk of sudden cardiac death? Are they aware of all these, of the possibilities? Are they aware of these risks? And I think we're trying to shy away from the paternalistic, you must do this, you can't do that parts of medicine. And so really, shared decision-making, extensive conversation regarding who the person is really important these days. And so, as I said, the pendulum is swinging. And so most patients can and should be advised to perform in light and moderate recreational activity. And then if they want to perform vigorous or highly competitive athletics, then that should be part of the shared decision model. And there is also an ORCA study right now. You can go read more about it at orcastudy.org. But this is the outcomes registry for cardiac conditions in athletes. And this is really a longitudinal study registry that's evaluating patients with hypertrophic cardiomyopathy and long QT syndrome to see if there are any clinical events, because we're only going to be able to elucidate these things once we get more data. So back to Mr. G. Okay, so I have an ICD. I've been genetically tested, but I'm still short of breath and fatigued all the time. Those things that we talked about really didn't fix my symptoms. What can we do about my symptoms? And so this is when we'll talk about treatment algorithms. Now, one caveat about treatment algorithms is that treatments are purely for symptoms. As we discussed, there are a large number of patients that are asymptomatic with hypertrophic cardiomyopathy, and those patients don't need treatment. Those patients can be monitored and very safely just watched in the outpatient setting. A lot of the times when I see patients in the HCM clinic, they're overly beta blocked with a heart rate in the 40s, and they feel terrible because they're on medicines, not because they're obstructing, but because they're being over medicated. So a lot of the times I'm taking off medications just as I'm giving medications. But for your symptomatic patients, there are a lot of medical options, and there are a lot of septal reduction. There are a lot of septal reduction therapies that we'll talk about as well too. What we're not going to be talking about, what's sort of out of the scope of this talk, is the patients with non-obstructive hypertrophic cardiomyopathy, non-obstructive symptomatic hypertrophic cardiomyopathy. That's the 4% of patients that end up going into heart transplant. And I think that's, as I said, out of the scope of today's talk. But suffice it to say, we've been using beta blockers, verapamil and disopyramide for many decades now with good efficacy. And really the goal of these medications is to reduce diastolic filling time, increase cardiac flow, and to improve cardiac output. And so beta blockers do a really, really good job of that. Calcium channel blockers do a really, really good job of that. I personally don't use a lot of disopyramide, but in patients with atrial fibrillation, it can be helpful because it's an adjunctive antiarrhythmic medication as well too. But it is plagued by a lot of side effects. And so the newest kid on the block are these cardiac myosin inhibitors. And so we'll talk about that a little bit. So cardiac myosin inhibitors work at the sarcomeric level. And so if we go back to our medical school days and we think about the myocytes of the heart, we recall that there are actin and myosin cross bridges that help contract the heart. We know that in HCM, there's an overabundance of these actin and myosin cross bridges. So what mavacamten does is that it targets these actin myosin cross bridges, it lessens them. And so what this does is it reduces contractility, which increases diastolic, which increases filling, and which improves cardiac output. And so this is really the first targeted therapy that we have for hypertrophic cardiomyopathy. And the Explorer HCM trial was the trial that led to its FDA approval. It was a randomized, double-blind, placebo-controlled phase 3 trial that studied patients with hypertrophic cardiomyopathy. And it studied patients with mavacamten and without mavacamten. And you'll notice here that the N was 251. And this seems rather low. When we talk about coronary disease trials, hypertension trials, CHF trials, we see N's in the thousands. And so this was quite low. But still, this is the highest volume studied to date on hypertrophic cardiomyopathy. Beta blockers, calcium channel blockers, disopyramide, those are all 2A recommendations based on expert opinion. There's never been a randomized control trial delineating the efficacy of those medications. And so I will say, because of the under recognition and under diagnosis of HCM, we do see much smaller sample sizes. But again, that's a caveat to take because of the small sample size. Another thing that I'll point out is that I'm sorry that these slides are a little hard to read, and that these are a little small, but it was a predominantly white population. So 94% of patients of both mavacamten and placebo were white, which is a little unusual for this day and age. And certainly hypertrophic cardiomyopathy is not a white disease. So that's just something to keep in mind. But the primary outcome of the Explorer-HCM trial was an increase in your peak VO2 as measured by CPET, as well as an improvement in New York Heart Association functional class. So there was an objective measurement as well as a subjective measurement. So the NYHA was the subjective measurement, and then the peak VO2 on CPET was the subjective measurement. And it met its primary endpoint at 37% of the treatment group compared to 70% of the placebo group. And so this was very statistically significant. But you might also say that that leaves 65% or so of patients that did not meet that primary outcome. And so some secondary observations that they saw on the Explorer trial was a change in resting and Valsalva LVOT gradient, a small change in LVEF, as well as a change in cardiac enzymes such as NT-proBNP and proBNP. The biggest thing that they saw was improvement in New York Heart Association class in 65%, as well as great improvement in the Kansas City Cardiomyopathy questionnaire in 52 of patients. The next study that I wanted to discuss was the Valor-HCM trial. So this was published about a year after the Explorer-HCM trial. And this was a somewhat sicker population, but this was building upon the previous Explorer data. And what the Valor-HCM study sought to find is that in a 16-week period, in patients that had hypertrophic cardiomyopathy that were originally scheduled for septal reduction therapy, could a trial of mavacamten decrease that need for septal reduction therapy? So in other words, all patients enrolled in this trial were eligible for septal reduction therapies. They were already prepared for either alcohol septal ablation or a surgical myectomy. They treated these patients for 16 weeks, and then at the end of that 16 weeks, saw who was either still eligible or who decided to proceed with septal reduction therapies. And the results were overwhelmingly positive. And so as you can see here, in patients on mavacamten, 82% of patients that previously were eligible became ineligible. And in the placebo group, that was 23%. And on the bottom here too, you can see the gradient reduction that you see. So at the end of the 16 weeks, there was a significant reduction in the LVOT gradient, both at rest and Valsalva, and that really sustained was sustained while on medical therapy at the end of 56 weeks. Most patients on mavacamten, 63%, also had improved their New York functional class, and over 27% of patients had functional improvement of greater than 2 classes. So it's the first myosin inhibitor, and like I said, it was FDA approved in April of 2022, but it's certainly not the last. And so this is the Sequoia trial that is currently enrolling. I think it actually just finished enrollment and is undergoing its data review now. But this is aficamten, which is sponsored by Cytokinetics. It's another myosin inhibitor in the market now. Reportedly, it has a shorter half-life. It has less CYP interactions. But we'll have to see what the Sequoia data reveals at the end. And so this is another patient that I had on Camzyos. So this is a 45-year-old gentleman who was previously diagnosed with hypertrophic cardiomyopathy in his 20s. His sister died of sudden cardiac arrest in her teens. He tests positive for mutation MYJ7. His daughter tests positive for MYJ7. He has an ICD implanted, and that's his EKG. And you can see here on the echocardiogram at the top, significant left ventricular hypertrophy, significant septal anterior motion at the bottom there. So he has classic hypertrophic cardiomyopathy, and he is extremely symptomatic. So at baseline, he has a peak gradient of 76 millimeters, and with Valsalva that increases to 90 millimeters. And this correlates with how poorly he feels. He's barely able to walk 10 minutes without getting short of breath. And this is while on toprol 200 milligrams, a massive dose of metoprolol. So after 4 weeks of mavacamten, his LVOT drops. He now has a peak gradient of 22 millimeters. And at the end of 12 weeks, you can see here, myocardium still looks okay, but looks much thinner. And at the bottom right there, much less aliasing in the LVOT, much less systolic anterior motion. and his peak gradient goes from 90 to a peak gradient of 38 at rest and 40 with Valsalva. So it's essentially half of what it was. Even more reassuringly, he feels much better on the medication. His murmur disappears, and he feels great. And so this medication has been really beneficial in our management of hypertrophic cardiomyopathy. But there are some caveats, right? It's a newer medication, and so the long-term effects are still unknown. How this affects people 5, 10, 15 years from now, we just don't know yet. There are long-term extension trials ongoing. There are cardiac MRI extension trials ongoing, but to date, we just don't have that information. There are multiple CYP drug interactions, which makes it a little tedious as well too. So simple drugs as well too, like Prilosec and fluconazole, all these CYP interactions can be really hard to discern. And for now, when they did the Explorer trial, they did see a decrease in EF in about 7% of patients, and this led to the concern of clinically relevant congestive heart failure. This is a temporary medication, so in all 7 circumstances, those LVEFs return to normal. But because of this, there is now a stringent REMS requirement, an echo requirement. So REMS is the risk event mitigation strategy. It's what high-risk medications undergoing FDA approval have to pursue when they're first being released. And so in order to be on mavacamten, an echocardiogram has to be assessed every 4 weeks, 8 weeks, 12 weeks when you're first prescribing it, and then every three months thereafterwards. So it's at 4, 8, 12 weeks, and then every 3 months thereafter. So obviously that is a lot of echocardiograms, and some of our patients do not live locally. They come from far away, so this is somewhat tedious. Some other things that we don't know is that can they serve as first-line therapies? As you saw in both the Explorer and the Valor trials, in both of those trials, patients were already on metoprolol. They were already on calcium channel blockers. And so if these can replace those medications is still unknown. And again, what disease-modifying things can this medication add for us? We know based on the trial data that there was a decrease in proBNP, there was a decrease in troponin, but does this translate to any decrease in wall thickness over time? We just don't know. And so for me, I think this is a good adjunct to our current armamentarium. It'll probably replace disopyramide for me because that drug is extremely poorly tolerated. I don't know that it'll be first-line therapy right now just because of cost and things like that. Metoprolol and calcium channel blockers are cheap, they're accessible. So I think those can and should remain first-line therapies. But I think these cardiac myosin inhibitors are an interesting class and certainly adjunctive to the current therapies that we have. So Mr. G returns. He unfortunately did not have a good of a response as the other patient that we saw. And despite 16 weeks of medical therapy and increasing up titration of beta blockers and cardiac myosin inhibitors, Mr. G continues to feel fatigued on a daily basis. His exercise capacity continues to decrease. And so this is where we consider septal reduction therapies. And so the two available are alcohol septal ablation and surgical myectomy. And surgical myectomy is a open heart bypass surgery where the surgeon just, you can see there, cuts part of that myocardium that's causing that obstruction. It's harder than it looks, I'm told, on that diagram over there. It can be very beneficial, which we'll talk about in a little bit. Alcohol septal ablation is a catheter-based procedure where we're injecting that first septal perforator of the myocardium that supplies the septum. And by killing that septum off, it decreases that gradient and decreases the wall thickness there. There are pros and cons to both of these. If you look at the survival of both alcohol septal ablation and surgical myectomy, they're basically equivalent, as you can see on the left, and that's age matched controls. But on the right, you can see that surgical myectomy, which you see in blue, has a much more sustained response compared to alcohol septal ablation. But the caveat to that, as we said, surgical myectomy is an open heart procedure. So the patients that are younger, surgically fit, are probably better able to tolerate that than your more elderly, more frail patients. And so delineating which one you choose, alcohol septal ablation or surgical myectomy, is really a discussion of the pros and cons. And so surgical myectomy, VSD, is longer hospital stays, it's more invasive, better for younger patients, whereas alcohol septal ablation, lower reduction, less sustained response over time, as we saw, higher rates of pacemaker implantation, and then higher percentage of reintervention, as we saw in that study above. No matter which one you choose, though, it's really the AHA recommendation is to go to a place that does a lot of them. And so this is an area of medicine where volume is certainly king. And so you really want to go to a high volume center that does either surgical myectomy or alcohol septal ablation, no matter what you choose. And because that'll really influence what your outcomes are. If you go to a really high volume center that does surgical myectomy, your survival rate can be less than half a percentage point. Sorry, your mortality can be less than half a percentage point. And so that's really good. So most patients will tolerate that. If you go to a lower volume center at a smaller community hospital, in a place that doesn't do a ton of them, then that mortality jumps up to 6%, 9%. And so it's really good to talk to the patients and to send them to a center of expertise where they do a lot of them, because that's where the outcomes will be the best. So Mr. G undergoes surgical myectomy. He does return to clinic 3 months later. He's still sore from surgery, but he's recovering. His breathlessness has improved tremendously. And as you can see on the right, his LV cavity looks somewhat better. The obstruction is certainly improved. And you can see that he has no obstruction anymore based on the LVOT gradients on the right. And hopefully you can see that one big theme that we've been talking about with all of his decisions is this idea of shared decision making. And this covers all aspects of the disease spectrum, from medical management to genetic testing, ICD implantation. This requires a really extensive shared decision making between what the patient wants, what his goals are, and what the recommendations are at the time, and what his risk tolerance is. And we're coming close to 1 o'clock, so I'll wrap it up. But the summary that I'd like to leave you with is that hypertrophic cardiomyopathy is now recognized as a relatively common, contemporary, and treatable disease. It's not inevitably progressive. It's got low mortality. And in fact, and this is an area that I like to instill upon patients when I see them in our HCM clinic, that it's got low mortality and it's compatible with either a low or extended life expectancy. Of course, it's very heterogeneous. No two patients are the same, and patients can display in a variety of mannerisms, as we've seen. And just a quick plug while we're here about our comprehensive HCM center. It takes a team. And so part of our comprehensive HCM center is advanced transplant cardiologists. So it's me and Dr. Berman, advanced imaging cardiologists, electrophysiologists, cardiac geneticists, cardiac thoracic surgeons, nurse navigators, and our sonographers, of course. And so it really does take a team to make this all put together. And I told you we weren't going to talk about the non-obstructive symptomatic population, but the one word that I'll say is that we are engaging in some research trials for that population. And so this is the Odyssey trial. We also have a quarterly support group. So if you do have patients with hypertrophic cardiomyopathy, a lot of them have not met other patients with it. And so we have our transplant psychologist there. This session happens to be a risk on sudden cardiac death. And it's a good time for patients to get together, meet each other, and learn more about their disease process. This is for your reference. These are the 2022 guidelines. After the 2020 guidelines, there were also some state-of-the-art reviews that I've found exceedingly helpful, and those are interspersed throughout this PowerPoint presentation as well too. So I want to thank you very much for your time. And again, I've hoped I impressed upon you that HCM is very treatable. It's very heterogeneous, but it's very fulfilling to treat. And there's a lot that we could do for these patients. So thank you very much for your time. I'm happy to take any comments or questions.
Thanks, Robbie. That's excellent. I can see why everybody told me you needed to speak. Excellent presentation. So very charismatic, and really loved your structure and your presentation. What questions do you guys have for Dr. Wu? It's like you wowed everybody.
My email is up there, and most of you a lot of you have my cell phone number, so very accessible. Feel free to reach out to me at any time.
Very good. Awesome. And great comments for folks saying awesome presentation, getting lots of claps. So awesome. Have a great day, everyone, and we'll see you next week, Thursday at noon.
Great.
Absolutely. Thanks, Robbie.
Thank you so much, everybody.
Take care. Bye.
Dr. Wu, are you still there?
I am, yes.
Did you want to stick around for a few minutes and see if we can fix that camera?
Sure.
Let me see if I can get Sheila back on.
Actually, I do have to go, if that's okay. Maybe we will need to fix this some other time.
That's just fine. If you want my help, reach out. Otherwise, submit a ticket to IT and they should be able to work you through it.
Sounds good. Thank you so much.
Thanks.